Chapter 6, the demand for medical insurance. Lecture 3, policies. If you wanted to compare the health insurance product basically before and after 1980s, we can see that before the 1980s, the health insurance product and the relationship between the patients, basically the consumers, insurers, and healthcare providers was much less complicated and easy to define compared to the after 1980s. Before 1980s, most of the consumers, basically the patients, buy their insurance through their employers, and they had a choice of healthcare providers. They could choose anybody they want, any doctor they want, and the doctor had the choice to prescribe any medical care they feel they wanted to, basically to each patient. And the insurance premium was determined by community rating based on the risk factors of the entire membership. So basically, the risk factors, the premium, reflect the average health risk factors of the entire population, basically. But after 1980s, this relationship between the patients, insurers, and healthcare providers were much more complicated. First of all, the patients had restriction in most of the time to what doctor, the provider they choose. The physicians, they have restriction to what to prescribe, and the insurance premium is determined nowadays based on the experience rating. Means that the insurance company, they group the people based on by their age, gender, occupation, type of occupation, and prior existence of the prior chronic disease. So recently, basically, female, they have to pay more than male. Elderly, they have to pay more higher premium than younger people, and those with prior existence of the basically chronic disease, they have to pay more than those people they have had not prior experience of the chronic diseases. So health insurance plan before the 1980s was very straightforward. It was based on the amount of deductible and copayment. Physicians were working in solo practice mostly, and they had full autonomy of prescribing whatever they think it's right. And the insurer, basically the financial risk was managed by paying the usual, customary or reasonable, which is called the UCR, charge for any medical services. So usually they were choosing the lowest amount between to pay to cover between the usual, customary, or reasonable charges. The insurers manage this basically only by managing this financial risk by paying the lowest amount based on the usual, customary, and reasonable charges. Before the 1980s, the physicians had full autonomy, and they could basically treat the patient in whatever way they wanted. And the patient had the choice of going to any providers. But after the 1980s, to control for the cost of healthcare, insurance company made it more restrictive. So before 1980s, basically the fee was the visit, doctor visit was based on mostly fee for services, very simple. But then after 1980s, the insurance companies, they are emphasizing on a cost-effective method of providing comprehensive services to enrollees. Means that they're trying to manage both the patients and the providers to choose the most cost-effective methods of the medical care. Then So after the 1980s, there was an integration of the financing and delivery of medical care. So to basically manage both the providers and the consumers to choose the most cost-effective methods of medical care. The network of the providers, reimbursement methods, basically change other than the UCR, which was very simple, basically based on the lowest fee for service in the market. And there are various review mechanisms to whenever there is basically a choice for treating a patient to find the most cost-effective actually mechanism to treat the patient. So and also the premium rate is based on the experience rating of the enrollees rather than the community rating. Means that they charge the customer for premium based on their risk factors, based on the age, gender, occupation, and type, if they had a prior chronic disease. So that's actually makes the market and the relationship between these three agents much more complicated than before 1980s. So after 1980s, there are three main types of managed care organization. We call that MCOs. The first one is the Health Maintenance Organization, HMO, which is the most restricted version of the managed care. And the second one is Preferred Provider Organization, we call PPO, which is the least restricted, basically, organization. And the third one is Point of Service Plan, which we call POS, which is between them. Let's start with the most restricted version of the managed care. The first type of health maintenance organization, the first type of managed care organization is a health maintenance organization, or HMO, which combines the financing and delivery of the care into one organization. So each patient has to choose basically one primary doctor, which actually acts as a gatekeeper. So if the patient needs any specialty or any special medical care, should be referred by that primary doctor. So like any specialty or any inpatient care should be basically referred by that gatekeeper, basically that primary doctor, which acts as a gatekeeper. So it's very restricted form. The most restricted type of basically managed care organization. The staff, so there are actually in this HMO, there are different types. In the first type, the staff model, which is basically the physicians are directly employed physicians by the HMO. So they basically paid by the HMO, and they treat the patient by the number. So they are paid by the number of the patient based on capitation, basically, not by the number of the times they see the patients, which actually sometimes is good. It's because it's more cost effective. The physicians, they don't want it to make the patients to come and basically be paid based on number of the visit. So it's basically they are paid by the number of the patients they are treating. The second type of the HMO is group model. So this group practice, they are employed by the HMOs. So basically they are paid by the HMOs. And the network model is it's basically more than one group practice. they are employed by the HMOs basically. They have to uh, follow the HMO's rules and restrictions, which are very restrictive because they have to listen to the HMOs to follow and prescribe the most cost effective type of treatment. Um, Otherwise, the HMO will not renew their contract with them. Um, Also, the four types of the HMOs is individual practice association, the same thing. They are employed by the HMOs and they are paid by volume, but by number of the patients they're treating based on capitation, not by fee for service. So these basically HMOs contracts with a number of the independent physicians from various types of practice settings and basically pay them based on their regularly if they follow their restricted rules or not. Otherwise, they don't renew their contract. So that's the very restrictive forms of managed care organization. So people were not happy with HMO, so therefore the insurance company came up with the new version of the managed care organization, which was less restricted. They called Preferred Provider Organization, PPO, which basically this PPO sets up a network of physicians and hospitals and providers, financial incentives to basically subscribers to acquire healthcare from the network. So it's still, there is a network, but you don't need a gatekeeper to go to the specialty. You can go to the specialty and basically without your permission from your referral from your primary doctor within the network. So within the network, you can go, you don't need a gatekeeper, basically, there is no gatekeeper, but it should be within the network. You can also go out of the network, but you have to pay more. So you have to pay more if you wanted to see physicians out of the network. This is the least restrictive version of the managed care organization. Here, physicians accept lower fees, and there is a steady supply of the patients, and there is no need for gatekeeper. That's the basically least restrictive version of the managed care organization, and is most of the people they prefer this version recently. The third type of managed care organization is the point of service POS plan, which is basically between the PPO and the most restrictive version of HMO. So in the in the POS is a generous coverage when enrollees use in the network services. There is a network of the physicians. So you can also choose out of the network, but you basically you have to pay more. So the difference between POS and PPO is that each enrollee has a gatekeeper compared to the PPOs that you don't need a primary doctor's referral if you wanted to see in a specialty or go to the inpatient basically services. But in this case, there is a gatekeeper. That's the difference. But this is something basically between the managed care and the PPO. Recently, the MCO status in 2011 was basically covered 99% of the all privately insured workers. Most of the number of the people they prefer the PPOs are increasing over the time, because it's the least restrictive version. 55% of the people they were under PPO in 2011, and then 17% under HMOs, and then 10% under POS. So this number of the people they prefer PPO are increasing over the time. Let's compare the different health insurance basically product or before after 1980s healthcare services, basically agents. In the left side, we have the basic features, which basically talking about the patient's financial incentives and consumers' management strategies and providers' financial and management strategies. Let's start with basically with the patient financial incentives, which, as we had before, are the deductibles, co-insurance, and premiums. They are very important in basically making the patients to use more healthcare products or medical care products or less. So those are basically the patient's financial incentives. Before the 1980s, there were no or low deductible, basically, and then with no co-insurance. And then the rating for the premium was basically based on the community rating. So there was no basically experience rating, means that the rate was very similar for most of the members, basically, of the health insurance. So the premium was almost equal for everybody. But after, with the restrictive insurance plans, after the 1980s, there are more significant deductibles, which basically making the patients to think about whether they really wanted medical care or so it's basically important for making decision for patients whether to start using their health insurance or not with a high deductible. Of course, the patients basically demand less, and based on what we talk, depends on the point of time of the care you need and based on how much really the patient needs. With the high co-insurance, again, that impacts the patients, basically, whether with the high insurance, the patients, they demand less. And as we talked, with a more restricted insurance plan, there is the premium is based on the experience rating, means that they charge each consumers based on their risk factors, based on their age, gender, and pre-existing chronic diseases, basically. Now, the second basic features is the consumers' management strategies that basically when the patient is deciding whether to have different medical care, such as screening or the choice of the providers, which there was no gatekeeper before the 1980s. There was no restrictions to whatever providers, whoever you wanted to choose as your doctor, or go to the specialty, or go to the any screening, basically. So there was no restriction previously. There was no need for pre-authorization for any medical care procedures you wanted to. But with the restrictive insurance plans, the consumers or patients must receive basically permission. In most of the cases, they have to, if they have a gatekeeper, they need a referrals. And in some cases, they have to basically choose their providers from the networks. Even in PPO, you have to use the physicians from the network, otherwise you have to pay more. Um, the other feature is the provider's financial incentives, which is the risk sharing or bonus arrangement. Previously, the physicians were reimbursed based on the UCR charges, means that based on the basically market rates were reimbursed. But after this 1980s, the physician providers are based on they are reimbursed based on the capitation mostly, means that the number of the patients they are treating with bonus or withhold, not number of the fee for service basically. It's basically if they can treat the number of the patients, basically they are reimbursed. So it's they have a bonus. They are rewarded by number of the patients they are treating, not based on the number of the visits, but by volume of the patients they have. Basically, for example, each physician covers, for example, to treat 50 patients, say that, and doesn't matter how many times those patients are visiting, but basically based on controlling their conditions, basically based on the fourth basic features is providers management strategies. So it means that the physicians previously before 1980s there was no restrictions on whatever they wanted to prescribe or as a procedures or treatment for the patients. So there was no utilization review previously. There was no practice guidelines or formularies. Physicians, they had a full authority to whatever they wanted to prescribe, any procedures they feel that's right for the patient. But with the restrictive insurance plans, there is an array of management strategy they have to follow, and so to make the best, most cost-effective type of procedures or treatment for each patient. So and the point here is that most of the physicians are employed by the insurance companies, and if they don't follow the most cost-effective strategies, then their contract will not be renewed, and they wanted to keep basically least expensive physicians, and they don't renew the contract of those physicians. They are very expensive. They are prescribing most expensive generic drugs or most expensive procedures for their patients. So basically, they wanted to keep the most cost-effective physicians that save money for their insurance companies. Looking at the before and after 1980s, we see that consumers directed healthcare plans was basically before 1980s. It was a patient-driven healthcare, which basically that was the reason the healthcare costs increased, and expenditure basically of the healthcare plan increased tremendously. And that was the reason everybody came up with the point that they have to come up with a plan to restrict these choices for the patients and for the providers. to decrease their healthcare costs after the 1980s. And they came up with this managed care insurers as a payers to manage the patients and the physicians, basically, to decrease the cost of healthcare system. So after 1980s, again, there were a lot of plans to make the both patients and providers more responsible. For example, for the consumer-directed healthcare plan, they came up with the consumer driven healthcare. They came up with the, for example, high deductible, $1,000 per person or $2,000 per family or more. So this deductible make the patients, consumers more responsible. So it gives these financial incentives for consumers to become more involved in purchasing decisions. Means that they don't spend plan for medical care if they really don't need that, because they have to pay. So this deductible makes them to feel that they have to pay at the beginning before basically the insurance company covers them. So in case of high deductible, the consumers are use medical care more wisely and shop for high value of medical care more basically wisely, choose more cost-effective type of medical care, and the time also is very important. So the point of care is very important, whether they really wanted to pay that deductible. So it depends on their condition, whether they're healthy and that going to the doctor is not very important, so they make the decision. The other plans, such as tax advantage saving accounts and then health reimbursement accounts, they help the consumers or basically patients to think ahead of time to save money for their medical care. So if they think that, for example, this year they need some dental plan, they can actually kind of save ahead of time for tax deductible, basically, in their tax deductible account, and say that if they need a dental plan to do a dental implant or some kind of different procedures, they can actually in advance make plan and make savings. And so this helps the patients to think about their plan, whether they really need that. So if they need that, it gives this incentive, okay, first of all, you have to use this deductible, you have to spend your money from your pocket, and second of all, you can make a plan and save money for the future medical plan. Like any other investment, you have to make a plan. So when we are looking at this incentive by high deductible and premiums, we have to also think from both sides whether these issue of consumers directed healthcare plans will basically favorable selection of these consumer directed health plans burden the sick and poor. So do you think those people with the pre-existing chronic disease, they cannot go and get the medical care they need because of the high deductible or high premium? It's unclear if these CDHPs will basically make the people to prevent the people to see their doctor or not. There is an uncertain, basically, a study about how this selection of the consumer-directed health plans actually affect the patient's incentive to use more or less the medical care. So the regulation of the MCO was basically targeted to give the incentive to the both providers and patients to reduce the um, basically um, quantity of the care um, by denying or scheming or uncostly. This should be quantity of care basically. But basically we want those people, they really need the medical treatment. They can actually um, have no restriction for taking their medical care. So yes, there are regulations to influence the MCO behavior, like anti-gag rules, and then limits on financial incentives and continuity of care, and expanding the right of the healthcare professional. For example, one of the regulation to influence the MCO behavior is on the anti-gag rules. For example, the gag rules is a rules established by managed care organization that prohibit physicians from discussing treatment option not covered by the health plan. So providing information on the limitation of the plan and commenting negatively about the plan to patients. So these are the basically restrictions of the MCO that should be limited basically. Um, so based on after the Affordable Care Act, um, so the Affordable Care Act tried to make this insurance affordable for the people. So basically, first of all, they took out these pre-existing chronic diseases, and then by availability of tax credit through the insurance exchanges, they made the insurance basically available from the a small business tax credit. By giving the small business tax credit, the employers they can actually afford to provide insurance for the employees. And so different types of imposition of the excise tax make the insurance affordable. Basically, that was the reason the number of the people without insurance decreased from 16% to 9%. And as we talked at the beginning of the lecture, with repealing the Affordable Care Act, this number will be increased by elimination of the tax exemption credit for the small businesses, and also for the people that individually buy the insurance, health insurance. This is the end of chapter 6.